This program is brought to you by Emory University.
Okay, good morning, everybody. Happy rainy Friday morning. Welcome to Friday Morning Fellows Conference. Our presenter this morning is Zakaria Almuwaqqat. Zakaria is a fourth year fellow, final year of fellowship. Did his medical school training in Jordan, did his residency at the University of Illinois, Chicago, came to Emory, was a hospitalist for a few years and got his MPH, joined our research track where he worked with Dr. Kayumi. And as you can see today, he is going to talk to us about low flow, low gradient aortic stenosis. Take it away, Zakaria.
Thank you, Dr. Williams. Good morning, everyone. So we'll start this presentation with a case of a patient presented, 67 years old, African-American female patient who presented with a few days of not feeling well and lower extremity edema with poor appetite. She had few months of history of exertional chest pain and shortness of breath. And her prior history include that coronary artery disease. She had bypass in 2007 and recent left heart cath a few months ago that showed native vessels that were almost occluded, and she had patent Lima-Toll AD and patent venous graft to the PDA. She also has a history of heart failure with reduced ejection fraction and EF of 30 to 35%, and this was several months prior to presentation. Also history of diabetes and CKD. She also had a recent diagnosis of aortic stenosis, and she's currently active smoker, but she had cut down to 5 cigarettes daily. So two recent ER admissions that were before this presentation. 3 months ago, she presented to an outside hospital and was admitted for chest pain. She had workup, including TTE showed that her EF was 25%, and she had moderate MAC and mild RV dilatation. And her AS, she was diagnosed with mild to moderate AS with a gradient of 22 and dimensionless index of 0.21. No further workup was done except for left heart cath, which did show the severe native disease and the patent grafts. And 1 month later after that, she also presented for decompensated heart failure, where her EF was steadily declined to 15-20%, and she had similar valvular findings, but this time cardiology was consulted and they diagnosed her of having low flow, low grade severe AS, and they did several medication changes, and they plan to optimize and work up for outpatient TAVR. So in this presentation, her blood pressure was 98/67. She was slightly tachycardic at 101. Temperature was 37.1, and she was setting 100% room air. She was, however, lethargic and had venous congestion with jugular venous distension and rales in her lungs, and she had soft S2 and systolic ejection murmur. She also did have significant lower extremity edema. She rapidly deteriorated in ER. Her labs showed hemoglobin 10.1, and sodium was slightly down to 128, and potassium was 6.8, and she had evidence of renal dysfunction with creatinine of 2.6 and evidence of transaminitis. So her workup in the ER showed that, as we see on the right side, her EKG did have non-specific STT changes that were concerned. They were not necessarily different from her prior presentation. She also had a transthoracic echo that showed that aortic valve area of 0.7 by planimetry. When we did that calculation for the gradient, we found she had a gradient of 27.7, a mean gradient of 27.7, and aortic valve area of calculated here of 0.6 to 0.7. And this is at the stroke volume calculated at 30 ml. So she became progressively hypotensive in the ER. She had evidence of acute kidney injury and shock liver. She was started on inotropes and pressors, and we had a swan placed at bedside. Her right heart cath number showed elevated CVP and pulmonary artery pressure, and as well as elevated wedge. Her mixed venous was down to 46%, and her cardiac index was down to 1.7, and cardiac output 3.2. SVR 1545. So this patient was stabilized for a day, but she initially had a little bit vague picture of fever despite negative culture and multi-organ failure. So she had a percutaneous balloon aortic valvuloplasty with a gradient improved from 35 to 20. She also, at the same time, had Impella CP insertion given her LVEDP elevated significantly to 35. The plan for her, there was a plan for her to have TAVR when stabilized. However, when she came out with the Impella CP, she continued to hemolyze immediately after that, and her renal function declined precipitously. Despite all the above, she remained in multi-organ dysfunction and was not a candidate for advanced heart failure therapy due to lack of social support. And then patient and family decided to pursue comfort care at this point. So that takes me to the objectives of this talk today, which we will be discussing the epidemiology of severe AS and under recognition. Also, we will be discussing the diagnosis as well as understanding disease paradigm of cardiac damage, and also understanding the presentation with cardiogenic shock and therapeutic options. So low flow, low gradient severe AS affect about 10 to 20% of severe AS population. There's a rising incidence overall due to rising number of older patients and older populations. In these patients, reduced ejection fraction could be related to concomitant cardiomyopathy, whether ischemic and non-ischemic, and also could be related to afterload mismatch. There is a higher prevalence of concurrent CAD among these patients than other severe AS populations. So this study looked at 32,000 patients in the Optum database in commercial insurance, basically found that a significant number of symptomatic severe AS are untreated. And as we see here over the year, the rate has declined, but still so far in 2016 is about 63% of patients who have indication for treatments, they have not been treated according to this study. And there's also significant racial disparities where there is non-Hispanic and Black more likely to be untreated than other ethnic groups. So that takes me to the way of diagnosing patients with low flow, low gradient AS, and this is a situation where we actually have a mean gradient that doesn't meet the criteria for severe, but having aortic valve area of 1 centimeter or less, or indexed valve area of less than 0.6. And these patients usually to be diagnosed with low flow, they have to have stroke volume that's indexed to the body surface area of less than 35. And the EF could be reduced or preserved. In those who are EF reduced, if their valve area, despite the butamine stress challenge, remained less than 1 centimeter, then they classify as classical low flow, low grade aortic stenosis. Among those who actually, with the butamine stress echo, their valve area increase, then those patients are considered not to have severe AS if they don't meet other criteria, which I will talk in the next slide. And those with preserved EF, there's some group of patients who have tend to have small ventricle and tend to have low stroke volume, but a preserved EF. Then these patients could be also assessed for a paradoxical low flow, low gradient, which is slightly different than the classical. The only difference just the EF is preserved. So once we have these patients underwent DSE, and it's a low dose, we go on a graded dosing from 5, 10, 15, and 20. And we assess for the increase in gradient and assess for the increase in aortic valve area. And for example, the first group on the left, that's those who had an area of less than 1 centimeters and a gradient of 40 during this test, they classify as severe AS. Those who have increase in the valve area to be more than 1 centimeter and their gradient drop below 40, if stay below 40, they are considered not severe AS, or what's called pseudo-severe AS. So this is the middle group, which might be a little confusing, and those patients could have different reasons. So those who had inadequate flow reserve, which means with dobutamine, they did not have an increment in their flow of about 20%. And those patients, it may be hard to decide based on the dobutamine stress echo on itself. So then these patients can be assessed further by MDCT, which is where we look at the calcification, the calcium score of the aortic valve, and then we compare it with a threshold of 2,000 for men and 1,200 for women. And also we look at the projected aortic valve area to normal flow rate. So if patients meet both criteria, which is having aortic valve calcification be less than the threshold and the projected area of the valve more than 1 centimeter, then the severe AS is excluded. So this is a way of how we calculate projected valve area, which is we look at the flow currently and we estimate the flow based on the change with a dobutamine, and then we try to estimate if this patient were to have a normal flow, which is 250 here, how big is the valve area going to be? So if patients don't meet this criteria and do not meet the criteria for calcification, they are excluded. So where did this aortic valve calcification functional significance came from? So there are multiple studies that have showed that aortic valve area strongly correlate with aortic valve calcification. So there we see in the first graph on the left-hand side, we see that how actually there's an inverse correlation of 63% between the valve area and the degree of the valve area and the degree of calcification. And also in the in graph C, we see how there's actually positive correlation between gradient and calcification. So these thresholds are different between men and women, and partly we see here how the degree of calcification tend to be higher in men overall, and those who actually have calcification score of 2,000 and above could have severe AS. Here in the first graph in men, we see that the fourth group has an index valve area of 0.6 or less, and then a gradient of 40 and above. They tend to have calcification 2,000 and above. So having calcium score below that could exclude severe AS in men. And then in women, that number is slightly different. So they this fourth group has a calcium score of 1,200 and above, and they had characteristics of severe AS. So the reason there is men and women differences. So there are different disease. There are different phenotypes of disease among men and women. And as we see here on the left side, men tend to have more of a calcific disease of the valve. They tend to have more calcium per fibrotic area. They also tend to have more severe CAD. In contrast, among women, the valve is more fibrotic and is less calcium associated with fibrosis and also less severe of coronary artery disease concomitantly. And as we see here in the right lower part of the slide, we see how valve weight by annulus area, the density increase by the weight. So there is some element of that men tend to accumulate more calcium over time than women, and that's what plays in threshold. However, this calcium scoring of the valve is completely absolute number. So that means those who have bigger annulus surface area could have higher calcium score, and those who have smaller annulus area could have lower score. So this is where the future implication of diagnosis could be, where future changes. This is a metric called aortic valve calcification density. And this is basically divide the aortic valve calcification that we get divided by the aortic annulus area. So this way we index for the annulus area, so we avoid comparing different valves that are drastically different in size. And this metric is also highly prognostic of mortality, as we see in the Kaplan curve in the lower part of this slide, how having severe calcification of the valve as defined by the density of aortic valve calcium is prognostic and does predict adverse cardiovascular events. So that takes me to that understanding of how aortic stenosis stages. That's a new understanding of over the past several years that have been developed to really quantify the degree of cardiac damage that is related to aortic stenosis. So in stage 0, for example, patient had just an isolated aortic stenosis, and as they progress through stage 1, they have more of left ventricular damage, and they tend to have more findings that are concerning for lower ejection fraction and increased LV mass index. And stage 2, when they have more left atrial damage, and that will lead to having an indexed left atrial volume more than 34, and having moderate to severe MR as well. And then they progress to stage 3, where there's a more of pulmonary vascular remodeling and tricuspid damage and pulmonary hypertension, and finally to RV damage when there's a moderate to severe right ventricular function impairment. So the importance of these stages comes from understanding that aortic stenosis is not necessarily an isolated valve disease, and it's more of stages that patients can go through. And these stages actually has an implication in the level of evidence for intervention for those who have stage 1 and above, and they do classify in grade 3, and by having the valve area less than 1 and having the indexed valve area to less than 0.6, and then grading of 40, they all fit into a class 1 indication. And those who have intermediate grade 2, they fit into class 2A or class 2B. And those who actually, regardless of the stage, they have grade 0, grade 1, they tend to have class 3, which is not indicated. And that's the importance of this staging, is showing how actually after intervention and after TAVR, these patients who had higher stages to begin with before the intervention tend to do poorly after the intervention. And as we see, the difference is very significant from stage 1 of 9% of mortality, overall mortality rate at 1 year after valve intervention, goes all the way up to 25%, the risk of all-cause mortality. And also the risk of heart failure, hospitalization, and other complication, they all trend in the same way. They all significantly higher in this stage 4 group. What about patients who had concomitant coronary artery disease and severe AS? These patients tend to do even more poorly. and they tend to have actually lower survival. Here, a study that actually looked at 81 patients and compared those with coronary artery disease without and those without, and found that actually having coronary artery disease, the median survival is close to 10 months of presentation. And that shows, and this graph shows how actually there's been an increase in using TAVR among cardiogenic shock patients, and this is how that it shows that starting from 2012 until 2016, there has been an increase in using TAVR for patients who are presenting with cardiogenic shock as a primary treatment. This study was more of a descriptive study that looked over TVT registry and found that actually that those patients who presented with cardiogenic shock who had TAVR, they had about 19% of mortality compared to 4.9 mortality rate among those who were not in shock. This is actually, the definition of cardiogenic shock in this registry included multiple things like using inotropes and using mechanical assist device before implantation and having cardiac arrest before or having bypass. Percutaneous balloon aortic valvoplasty does actually eliminate the futility concern mostly because it's a simple procedure and there's no excessive cost with that. In contrast, TAVR as a strategy, as a primary strategy, can be more efficacious, but it's also can have less of a post-procedural AI. In contrast, this strategy tend to be less appropriate for sicker patients or those who actually need an emergency procedure or those who have unknown life expectancy or their life expectancy less than 1 year. So that's also this slide showed the importance of actually for those who like to improve with intervention, valve intervention, and they have the severe cardiomyopathy, it is important that we consider referral for advanced therapy of those patients. This paper shows that actually there is a very golden window, a narrow window for referral of patients who are presenting with heart failure. And the idea of this slide to show actually this timely referral before multi-organ dysfunction is important. In our patients, these were not appropriate because the patient were not thinking, or not considering advanced heart failure therapy, and this also did not meet the social support criteria. So in conclusions, low flow, low gradient aortic stenosis continue to be misunderstood, and that's because of the diagnosis and the treatment are sometimes complex. The vitamin shortage currently is a challenge, so CT is taking over most of the decision-making at this point. Rescue percutaneous balloon aortic valvoplasty remained the first line of therapy among the sickest patients. However, primary TAVR is an option among certain patients who are less sick and they have life expectancy of more than 1 to 2 years. For those who fail to improve, earlier referral for advanced therapy is needed. At this point, I want to thank everyone for attending this session, and then I'd like to thank Dr. Neil Dickert and Dr. Patrick Gleason for their help with the presentation. And I also would like to thank the CCU team who took care of this patient. I'll take any questions.
Thanks, Zakaria. Very good. I want to clarify something you said. I mean, you mentioned the dobutamine, the utility role of dobutamine echo for patients with low flow, low gradient AS. One clarification, you mentioned the patients with paradoxical low flow, low gradient AS, those with preserved LV function. Generally, we would not recommend a DSE for those patients, more reserved for those with reduced EF, and we would recommend other means of whether it's CT or cath lab evaluation for those with preserved EF. And, so again, dobutamine would more be reserved for patients with EFs less than 45%. I just want to give a little sort of near historical perspective, low flow, low gradient AS used to be a real, less a diagnostic dilemma, more a therapeutic dilemma, because before TAVR was so readily available and widespread, it was trying to figure out who would benefit and or survive surgery, amongst this group. So that's what a lot of the testing and the sort of hand-wringing that we would have over these patients regarded, is who would benefit in terms of their ventricular function, and who was of sufficiently low enough risk surgically, to survive the surgery and the post surgical period. So that was sort of the big issue before, in the past. I think now in the era of TAVR, it's less, we're less concerned with things like contractile reserve and things like that, because it doesn't matter as much. It's a lot. The barrier for entry for treatment for these folks is less, and the likelihood of survival is greater with TAVR as opposed to SAVR. So it's more just, like you said, identifying these patients before they get to the point that this unfortunate lady got to, where she was really too sick to be treated, and then referring them for TAVR, if appropriate, which is, it's just a lot simpler calculus these days in the era of TAVR. I don't really have a question. That was sort of my comments, and how this treatment sort of algorithm has changed over the years.
Zakaria, Stan Sherman. I use the VTI index a lot more, because I find that the techs they're trying to get that orifice area. You can really throw off your true aortic valve area with some funny measurements there. Did you read more about the VTI index in terms of it being less than 0.25 as being, to me, that's a huge warning that you've got severe AS?
Yes, absolutely. There's some evidence of that, and the mainstream and the main papers are making sure that we look at the aortic valve area in general, but that's definitely a concern, is that sometimes that measurement can be off.
Yeah, I mean, you'd mentioned that earlier echo report where they had sort of underestimated the severity of the AS, but you astutely brought up that there were clues, right? Like the VTI index was, dimensionless index was 0.21. The other sort of just trick thing, look, when the mean gradient and the EF are pretty close to the same number, it's probably severe, or close to it. Just as a very, I think her mean gradient was in the 20s and her EF was in the 20s on that initial, even though they'd read it, they had read the echo as mild AS or whatever it was. So, but yeah, a good point from Dr.
Yes,
Sherman.
absolutely. Yeah, I definitely, looking back at that, and the debutamine stress echo is more of a, used to be a prognostic test, and where you actually identify those who have risk of having cardiogenic shock during surgical aortic valve replacement. Now with TAVR technology, this is less of a concern, of course, and they're more, like Dr. William mentioned, there are less barriers for treatment in general.
I mean, yeah, we used to do these DSCs a lot, and we just don't anymore, like you said, for a couple of reasons. One is we used to be more concerned with the prognostic value of the DSCs, how well their stroke volume, et cetera, improve with dobutamine. That is just less relevant these days if you're not referring for surgery. And like you said, with the advent of CT, you can, the calcium score of the valve can give you an idea whether it's severe or not. And also you can get very accurate planimetered, in some cases planimetered valve areas. So a lot of times it does the job of the DSC itself. So it's just not as important or as frequently used. Furthermore, like you said, there's a dobutamine shortage, which also cuts down on it. But we used to do these low dose DSCs pretty regularly for these low flow, low gradient patients, and just don't anymore.
Mm-hmm, absolutely.
One of the issues that Zakaria and I talked about when he was preparing this was public reporting in TAVR, which, you know, in these cases is relevant because, you know, the difference between a balloon valvuloplasty and a TAVR from a procedural standpoint is not that different, right? But in these really sick patients, sometimes you'll see that they opt for, and so that gets into questions about you know, resource utilization in really sick patients, and but public reporting certainly is a very central issue when you know, trying to think about these patients, because you know, you end up with you know, publicly reported 30-day mortalities and things like that that certainly affect that. And I don't know if, Neil, you want to talk about that, as we've seen in the coronary realm as well, but in the TAVR realm, it's relevant because, to Robbie's point, it is quite easy to do, you know. So we're often asked, well, why not just do it? And so we get into these kind of ethical dilemmas about, you know, who we're going to take chances on, so to speak.
Yeah, I'm happy to sort of weigh in, at least to, you know, from the perspective of the team taking care of this woman at the time. You know, she, I think in her case, the bigger issue was just it was far from clear that that we had a shot at a good outcome. You know, I don't think the reporting issue necessarily played a role. It's a big sort of big picture role. I think in this particular case, she had kind of multi-organ failure, fever. This was definitely a sort of Hail Mary to see if we could right the ship, with the idea that, you know, this would give us a sense of whether that was really even, whether we were even at the spot where fixing the aortic stenosis would even be helpful. She actually had a pretty good result with the valvuloplasty from a gradient reduction perspective, and didn't have a lot of AI. I think the one thing that was interesting is, you know, in the context of going in for the procedure, you know, we'd sort of hoped to put in a balloon pump. She wound up getting an Impella because her wedge was pretty high. She hemolyzed faster than anybody I've ever seen, you know, with an Impella device. She basically came back immediately, you know, had you know, tea-colored urine, and you know, went into acute renal failure, and that was ball game. So I don't know whether you guys have seen, I was curious, Patrick or others who have been involved in thinking about this, whether in really tight valves, when we've got something that's sort of hanging out, taking up a space occupying entity across a really tight valve, have you guys seen a lot more hemolysis with Impellas in that population?
It's not a common thing that we do in general. Yeah. So I don't have a lot of experience to draw on.
Yeah, I think the issue about report, you mentioned it. I'll just to sort of close the loop. It's worth your reference to the coronary space is important. There are, you know, they're pretty robust data that when public reporting started to be implemented related to particularly care of acute MI, we saw decreased utilization of indicated PCI for patients that were, you know, high risk coming in with STEMI and cardiogenic shock. It's a population that clearly needed that procedure because, you know, that's a very high mortality population, and people were averse to taking to the cath lab because they were going to get dinged in terms of numbers. And there's population level data that was really happening. So it's a really important piece of the puzzle when thinking about the role of public reporting. You know, like I said, I think in this particular case, I don't think it was part of the decision making. But when you look more broadly, as we see more people coming in with advanced aortic stenosis who are coming in sick, I think it certainly could play a role in a bigger picture scale. I think just to add one more thing, if it doesn't look anybody else raising their hand, but I think, you know, the main thing that this patient really showed us was, you know, she had some known reduced ejection fraction, known ischemic disease, and she had echoes when you go back quite a bit that certainly suggested that her aortic valve may have been playing a a role, and it was absolutely under-recognized. She was not cared for within our system. The first time she was within our system was basically right before she came into the unit. And that was when, as Zakaria mentioned, it was noted that she, had a valve that was contributing and needed workup, but it's unfortunate she'd been cared for kind of outside, and it just shows that this is an entity that can easily get missed, if you're not really aware of it.
Okay, well, thank you again, Zakaria, for that presentation and everyone for their comments. Any other questions? All right, well, everybody have a good Friday. We'll be back with an M&M conference next Friday.
The preceding program is copyrighted by Emory University.